We're going to spend 3 half hours talking about either NSTEMI in sort of 2 parts and then STEMI as well, because last year and the year before, the American Heart Association and American College of Cardiology updated all of their guidelines. And I think it's important for us to kind of know what the changes were, but what we're going to start with in this talk, which is the first of the 3, is we're going to talk a little bit about guidelines themselves. We have been kind of inundated with guidelines. In fact, there are guideline clearinghouses. There are whole websites that will kind of screen the guidelines for you. There's just so much out there. And a lot of us, especially guidelines like the American Heart Association or ACC guidelines, feel sort of obligated because they're out there to follow these things. The most sort of well-known of which is ACLS, right? The guideline that we teach our paramedics and we kind of go by as far as resuscitation is concerned. There's a couple things about guidelines, though, that I want to talk about in the first half of this talk to kind of put them in perspective. The person who wrote this chapter is David Newman, and if you follow, he has a blog called the NNT, the Number Needed to Treat. He's written a couple of books, and he's an academician back in New York, and he's very much a skeptic and is really an analytical thinker in almost a class of his own. He was able to kind of pull apart things in ways that are incredibly logical and kind of deep dive into things. And he wrote this chapter and brings up some things about guidelines that I think are important for all of us to at least think about. Our job is incredibly difficult. I was chatting with a couple people yesterday during the break about all the things we're sort of expected to do. Be accurate, be fast, be kind, be up on things, know all the rules and regulations, do the right thing all the time, even if it sometimes goes against what you think may be right. We're put in a hard position. Guidelines are an easy way to sort of step in and say, well, this is what the guideline says, this is what I'm going to do. But I think it helps to understand where they came from. And if guidelines don't ring quite true to you, that actually may be just fine, that you may be very accurate. So let's talk a little bit about guidelines themselves. Abstract number 1 sort of looks at published literature, just the concept, because guidelines theoretically are based on literature. And this is actually really interesting. The authors of this wrote this abstract on the next one. And what they did in this one is they went to the New England Journal, one of those, everyone have a moment of silence and honor the New England Journal, one of the mega journals out there. And they went to the New England Journal and looked at 10 years of publications that had to do with clinical practice. So they looked at everything published. They pulled out the articles that had to do with some sort of addressing of a clinical practice, and there were jillions of them. There were something like 1,300 articles in those 10 years, which none of us will ever keep up on. That's a single journal. There are a gazillion journals out there. And they looked at what happened with those articles. When they looked at, when the article was studying something, what did it say about particularly established medical practices? So when a study looked at something we'd already done and compared a practice or addressed a practice or looked to see if it actually made a difference, what did they find? And it turns out that almost half of the articles that addressed a previously established medical practice reversed that practice. So the articles themselves, just the articles from which we pull our guidelines, already start to challenge practices that have been in place for a long time. And we've all lived through these things. The abstract number 2 addresses the cardiology literature specifically. What is it that happened in the cardiology literature over that time period, addressing medical practices, and what did we do about those things? And what's fascinating, Amal Mattu, I'd mentioned him yesterday, I just think he's the greatest guy ever. He's super humble, super smart, just a wonderful person. He wrote an email to Rick Bucata as this particular paper came out and said, I've been lecturing on cardiology for almost 15 years. He said, I've had to, I stand up there one year and say, this is what you do, and then the next year I have to come up and say, not so much. Maybe we don't really need to do that. And those of us who have been practicing a while, we used to treat PVCs all the time in anyone who might have had an MI, and we were killing people doing that. We've reversed practices over the years, which I think, and there's a sort of data in here that talks about what they are, but it kind of gives you some empowerment, I guess, when a guideline comes out that says you must do X, to just stand back a second, because if you wait long enough, odds are about 50-50 that thing may get reversed at some point in time. So the latest one for us recently is temperature control after hypothermia after cardiac arrest, which last iteration of ACLS was something we all had to do. We all went through all this rigmarole to get it all done. And now the pretty well done research is saying maybe not so much. Maybe it really doesn't help as much as we thought it did. So all of this just keeps in mind to keep a little bit of a step back and say, yeah, that's a guideline and it's published out there, but it may not be completely set in stone. And we'll talk about things where you can really easily fudge and not get yourself into trouble. So there are a lot of things out there in the guidelines that are an issue. The third thing that comes up in issues, as far as abstract number 3, this is written by Jeannie Lenzer. Jeannie Lenzer is not a physician. She's an investigative journalist, and she knows Jerry very well. They've been friends for quite some time. And she writes really interesting kind of deep dive investigative journalistic articles that often get published in the British Medical Journal. That's one of sort of her go-to places. She's pretty well respected in the field, and she pushes buttons, and she gets into places that are uncomfortable for people that get involved in doing things like writing guidelines. In the third abstract there, she looks at how these guidelines get developed and conflict of interest. And it's just the dirty little backdoor secret of a lot, not so much of a secret anymore, of a lot of how guidelines are developed, where people who are on the panels that develop these guidelines may have ties to industry, one way or another. They were on the Speakers Bureau and got paid $5,000 a shot for lecturing. You know, I wouldn't mind making that. I don't make anywhere near that when I lecture. But they get paid, or they get research funding, or they get something that ties them to industry. And the data is kind of alarming. What she found when she really did a deep dive into this is that basically between 70 and 90% of leadership in these guideline developing committees has ties to industry. That's enormous. And I don't want to bash things entirely, but what it does is makes you have to step back a second and say, you know that weird page with the tiny, tiny font that says conflict of interest and do they have it? You have to go look there. You have to pay a little bit of attention. Because if that page has, there's one article I read that was published that had, each author had no less than like 5 lines of conflict of interest that were written at the end of the article in little teeny tiny print. Well, if there's that much conflict, I'm not sure how much you really can trust the study. And it's not that they're being evil, mean people. It's just that they have, and we talked about bias. There's an inherent bias that gets built into all of this sort of process. So Jeannie's articles basically said this is an issue, and I'll get into a little bit of detail in a second on how much of an issue when we get into the last set of guidelines. All right, the last little bit of this, as far as if literature changes, why does it change? Abstract number 4 is an interesting article that looks at the ACC AHA guidelines specifically, which is now we're drilling down to what we're talking about today. And what they did in this is they looked at, so I want to back up a second. When they develop a guideline, there's this, I don't have it color, but there's this table that's always in the front that across the top lists basically classes of recommendation, and down the side lists levels of strength of evidence. And most of us gloss this over. We just kind of say, whatever, ew, it's that researchy, statisticky thing, ew, I don't care. What this does, the one across the top, basically the class's recommendation, if it's a class 1 recommendation, and so it says do X, parentheses, class 1 recommendation, that basically says it is beneficial to everyone, you need to do this. Class 2 is it may be beneficial, okay, and enough that you should consider doing it. Class 3 is either neutral or more often harmful. Don't do this. And you'll find that most of the Class 3 recommendations are worded in the do not sort of category. They're worded in that sort of verbiage. That's the recommendation across the top. Down here are the levels of strength of evidence. So a level 1 is basically randomized controlled trials with multiple patient populations. You know, multiple institution studies, the ones where you have lots of different kinds of people, lots of different kinds of practice settings, and a bunch of people involved in that. That's basically the level 1 evidence. Level 2 is a randomized controlled trial, maybe in a single institution, or only one that's out there. And some case reports might be thrown in there, some sort of non-controlled studies. Class 3 is either case reports and a little smidgen here and there, or what's called GOBSAT. Good old boys sitting around talking and deciding this is what they think. That is important. So most of us ignore that page and just charge ahead and ignore that page. The reason it's important not to ignore that page is brought out in abstract number 4. What abstract number 4 did is they went back and looked at all of the recommendations, and it's alarming. Over, I think this is a 10-year period, there were 53 sets of guidelines that came out. No, it was a 20-year period. 53 sets of guidelines that came out from the ACC AHA. There were a total of 7,000 recommendations in this. How are we ever supposed to keep up on this stuff? It's crazy. And what they said is, over time they changed. And in fact, half of the recommendations changed. I mentioned this before. On only 11% of the recommendations, when they actually looked at how strong was the evidence on basing that recommendation, only 1 in 10 was based on really good multi-level trials, multinational trials, all this, multi-institution trials. And it makes sense that a lot of this gets changed over time because the data on which it is based is squishy. It's soft, it's squishy stuff. So it makes some sense that these must do this. We take these guidelines as sort of, a stamp, you have to do it. It makes sense why they evolve and change, because they feel they have to make some recommendation on something, they do the best they can. But if the literature is terrible, it makes sense that if more comes out later, it will change. So the whole take-home point on that to me is to think about that, if this isn't something that's really truly life or death here, and if it's sort of a little soft thing where the cardiologist can do it later if they want to, or I'm not obligated to do this now because it just sounds a little weird, I'm not going to do it. And you are not, just because it's stamped into a guideline doesn't mean you have to do it. We feel very obligated with some of these cardiology guidelines because there's a lot tied to it. ACLS is considered a standard, and honestly, in court, these are things that will get thrown in your face. But the reality is those same guidelines have a counter guideline that's published often at the same time. So I think the take home is you are not obligated by the fact it's in the guideline that is stamped by some big mega organization. It does not obligate you to follow it, sort of hook, line, and sinker. You can actually be discerning on what you decide to use. I think this data gives you a little bit more sort of comfort if you say, no, that's just silly. I'm just not going to do that. That's silly. Now, the last little bit is the conflict of interest piece. So the appalling thing to me about the AHA-ACC is that until 2010, they had no set policy about conflict of interest. Until 2010. That's absurd. That is absurd. This is the page that addresses conflict of interest in that 156-page guideline that came out. This is what they say, and see how you feel about this. So the members have to be volunteers. That's all fine. That means they're not getting paid to do this particular guideline. The task force makes every effort to avoid actual, potential, or perceived conflicts of interest that might arise through relationships with industry, which has its own RWI, its own little, they call RWI now. All of the members are required to fully disclose current industry relationships, yay, or personal interests from 12 months before initiation of the guideline. 1 year. That's very big of them. That is appalling to me. They should have to disclose if they ever had a tie to industry of any kind, and then either recuse themselves or have some sort of recommendation as far as not being able to be on it at all. The 1 year thing to me is just lip service. That really bothers me. They made a big to-do about we don't do conflict of interest anymore, and then this is how they do it. It's just weenie and wimpy, and I think it's just lip service. It's appalling to me. It just really bugs me. And it filtered down where it really blew up is in the statin guideline. So the statin guideline, this isn't for us, this is for just general statin approach. That statin guideline that came out 6 months ago has been ripped to shreds on every level. By academicians, by practitioners in the community, by people that have to fund this. The statin guideline that came out 6 months ago says 1/3 to 40% of Americans need to be on a statin. No joke. I mean, if you've invested in those companies, God bless you, because there's a ka-ching. However, it's based not on much. And the abstract that's in here, there's actually the last one in this section, is an editorial written by a rather prominent cardiologist who basically got so disgusted with the process, he just scathingly rips it to shreds in his editorial and talks about how it all happened. It took 5 years to develop that statin guideline. No guideline takes 5 years. None. No guideline takes 5 years. And what happened in this particular group was sponsored by the NIH. God bless them. The NIH said, we really want to get some science out there and really figure out what we need to do. So they put this group of people together who basically fought internally for quite some time, to the point where half of the members of the original committee quit. It's like, I'm done. I'm not doing this. I'm not fighting this. I quit. The remaining half wrote a guideline. The NIH looked at it and said, we can't support this. This process isn't working. This guideline isn't working. We can't support it. And the NIH pulled out as a sponsor. The American College of Cardiology and the American Heart Association stepped in and basically published it without any reworking of the data or any changing of the committee, which is a problem. It was a problem, and this guy basically says this is wrong. There was conflict of interest involved. There were people that had no real hard data to base this on. This is wrong. So the whole point of bashing this, I don't mean to beat it to death, but we kind of look at guidelines as this wow thing. Please don't. Be as skeptical as you are with everything else. All it is data that's kind of already messy with people that have already opinions and maybe conflicts that throw it into something that gets stamped with something fancy. It's no better than any other thing out there, and just kind of keep that in mind. That being said, let's get into the meat of the guideline itself. So this is basically what are the general recommendations. And as far as getting if you kind of have your approach to using nitro and beta blockers and calcium channel blockers, and you kind of got it from the last set of guidelines, keep it. That didn't change. Okay, the recommendations as far as medications involved in treating down to, we're going to talk about heparin and statins separately, but the basic stuff, when to use nitro, when to use, giving an aspirin, all of that's the same. The only thing that changed a little bit is oxygen therapy. And actually in the STEMI guideline, he's going to talk about that a little bit more. Basically, the bottom line here is not everybody needs it. And in fact, it may be some harm. And he'll get more into that in the STEMI guideline, but just know that one, 90% sat, let them sit. Okay, under that, stick some oxygen on. So basically, they don't go crazy with that. How about anticoagulation? For a long time, we had protocols, actually, where I used to work, where anybody who came in with what was unstable angina or an NSTEMI got given heparin. Okay, they just all did. It was like part of this protocol. You check the boxes. And now that we have EHRs, I bet a lot of you back in your joint, if you have an unstable angina or NSTEMI kind of person, an ACS person you're admitting, there's a box that you can click that has it as part of the protocol. Does it work? I'll tell you, this is a big problem. Actually, anticoagulation doesn't necessarily work, and it actually can cause some harm. So the papers that look at this, if you do a deep dive into this, there's abstract number 7 is a wonderful kind of landmark older paper that looks at unfractionated heparin in these groups. But what they basically find here, as far as this NSTEMI, before I get into this, what they did in this guideline that's different from previous guidelines is they lump together NSTEMI, which is troponin positive, and unstable angina into a thing called NSTE-ACS. Big non-ST elevation ACS. So they're taking troponin positive and troponin negative people and lumping them together as if they're the same. And I think that is a huge downfall of this guideline because the literature says they are not the same. Okay, in the subtle changes of things like anticoagulation, they are not the same. They are and we tend to get that sort of ACS group as we are more and more afraid of missing NMIs. We're throwing a lot of sort of really low-risk people in there. So that group encompasses wow, this guy looked like he was having an MI. It wasn't a STEMI, but boy, his troponin came back at 5. And that, a little bit of maybe chest pain for a little while. I just want to watch him. It puts all those people in the same group. They're not the same at all. So when it comes to anticoagulation, the heparins themselves, we know that it is one of the most lethal drugs we give in the hospital. Low molecular weight heparin has actually improved that some. Some of the sort of fluctuations in their anticoagulation status becomes less of an issue. That's better, but it's not completely benign. You still have bleeding problems. You still have thrombocytopenia with low molecular weight heparin. Should you be giving this to everybody? Absolutely not. It turns out basically in the low risk group, it does nothing and actually can cause some harm. And there's some data in here that looks at this. The bottom line to me with this, if you look at the literature, is if somebody has a stent in and they come in with chest pain, they get anticoagulation from me. Okay, they get low molecular weight heparin. If they have an NSTEMI, their troponin comes back positive, they get heparin. And what I'm getting from that is I don't change their death rate. I don't change it. What I get is a decreased recurrence of angina this episode. That's what I'm getting from that. But if it's somebody that's just in the kind of squishy area where I'm a little worried about its ACS, I'm not super worried and their troponin's not positive, you don't have to give it. And in fact, there's potentially more harm. What the American College of Cardiology basically says with this is that it should be given in all patients in this NSTE-ACS group that they're throwing it in there. I think that's wrong. And I don't think they can support it at all in the literature, but it's in there. So the reality is that what they do, though, is they don't give you a timeline, so let your cardiology colleagues do this if they want to, but I don't think you have to. How about statins? Statins, so the recommendation on statins is early initiation of high-intensity statins are recommended in this group. But they don't give a timing, they don't give a dosing specifically, they just say early initiation of high-intensity statins. It gets you off the hook, but let me tell you, this is the area I wonder the most about. The stroke concerns aside, which is a different issue. People with heart attacks, there's a stroke issue that comes along with that. That's separate. Just the ACS event itself. The literature absolutely does not support giving statins across the board for this group. STEMI, it's a little different. For this group, and actually the literature that's even industry funded says you don't get much for this. And let me show you how this works. There's a bunch of papers in here. Abstract number 8 is an industry-sponsored study. They used atorvastatin versus placebo. This was 3,000 patients, nice big study group. Followed them for 4 weeks. I'm not sure that's quite long enough. They looked at lipid profiles, et cetera, and what they found is their combined endpoint, come back to that, it's a primary endpoint. They picked a combined primary endpoint up front. They set it up front, God bless them, and they said there's a decrease in, if they get the statins, there's a 2.6% absolute decrease in the risk of our primary combined endpoint. So give a statin. 2.6%, that's pretty good. You got to go back and look at the combined endpoint. So so you read a paper that says combined endpoint, you've got to look at what's in there. If the combined endpoint was death, recurrent MI, and hangnails, and death and recurrent MI were the same, but hangnails were different, I wouldn't care. So you got to be careful with combined endpoints. What they did in this paper, death was in there, I'm with you. Non-fatal MI, I'm with you. Resuscitated cardiac arrest, that's kind of important. Recurrent symptomatic ischemia. That was another endpoint, and that's the only endpoint that made a difference. It didn't change death, it didn't change non-fatal MI, it didn't change resuscitated cardiac arrest. It just changed basically recurrent angina to give a statin. You have to decide if that's an important endpoint, but that's the only endpoint that made a difference in giving a statin, and there's paper after paper after paper that shows that. You don't change the biggies, you change the little one. And so are we going to give everybody a statin to change something that honestly isn't a major primary endpoint? And you're going to have to decide, but all of the literature says not so much. Now, to be fair, this paper says that, so the number needed to treat was 38, and again, what you're getting is that the recurrent ischemia angina group. That's all you're changing in that. But they also found there was a number needed to harm, that 53 people, if you gave it to 53 people, one person would be harmed. That's an important, anytime there's a number needed to treat, I want to know a number needed to harm. So this, I need to know the balance. Well, is it worth it? But part of that is, wait a second, what's the harm here? What harm is this actually? All the harm is a bump in liver enzymes. Honestly, if there's a bump in liver enzymes, you take them off the drug, no big deal. So that to me is not, that doesn't persuade me not to do it because of the number needed to harm. What persuades me not to do it is a lot of people are going to get a drug that they don't need that's expensive that's not going to really change the things that matter. And the literature that's even from drug companies basically says the exact same thing. And if you follow them out even further, that effect goes away. So if you follow them out long term, that particular effect even goes away. So you don't really get much. There's all the papers in here say the same thing. All of them do. And why the ACC AHA came out with saying give them to everybody, I'm not sure. I don't know. You're going to have to decide for yourself why that is. But fortunately, they didn't say when, and so you don't need to start these in the ER. You don't need to sort of start the process where everybody's now on a statin forever. You don't have to start that. The last little bit of this part of the guide, we're going to talk, so actually David Glazer's going to talk to you about the other half of this talk, but the last part of this is PCI. Is PCI helpful in this NSTE ACS group? So should we be shipping all these people to PCI centers, or those of us that are in those kinds of centers, shipping them up to the cath lab? If it turns out that's beneficial, this is a really big system issue, right? If it really helps people with NSTEMIs and ACS, unstable angina, if it really helps them, we've got a big population of people that we should be centralizing into places where we can do this. It's really important to know if this is helpful. The abstracts that look at this kind of go through, well, we'll talk about this in a sec, because it's fascinating. One would think, I'm having an MI, there's no ST elevation going on, but I am having heart damage here. I am having heart damage. Logic would say, go in there, find the bugger lesion, and put a stent in it and make it go away. Fix it. It turns out that doesn't necessarily help you, which I love when people finally look at the literature and say, yeah, logically that makes some sense, but you know what? It doesn't help people, and it really doesn't help people. So the abstracts look at, so what the ACC AHA says, as far as the approach to this, is that their quote is, consider PCI in people who are not initially stabilized, and my take on that is the can't control their chest pain group. And they don't specify what that is, that's sort of my take. And elevated risk of clinical events. Now, I have really no idea what that means. I honestly, I mean, we could come up with a list of things maybe, but I don't know what that means. And that's what they say, consider PCI and these two groups. What do I do with that? I have no idea what to do with that. Does that mean troponin positive people? Does that mean somebody who has bad lung disease where a heart attack would make things in the big picture worse? I don't know what that means. I have no idea. So that's their recommendation that's in black and white on a piece of paper. If you look at the data, though, of what happens if you take this not STEMI group, they're either having troponin leak, true NSTEMIs, or they're really, truly what you think is unstable angina. Does PCI help? The VA study, which is abstract number 11, looked at 920 true NSTEMIs. This was not the unstable angina group. This is the real troponin leak NSTEMI, the real deal, non-QA of MI people. They randomized them to early conservative management, so they get meds, they get lifestyle control, et cetera, hypertension control, which is key, or they went to early PCI. And they looked at what happened to these people. What was fascinating, they followed them 2 years. They did a pretty good drill down. And actually, there's a follow-up study that follows for 3 and 4 years what happens to the people. What they basically found is there was no difference in death or non-fatal MI. If you had early PCI, this is people with a true NSTEMI. If you had early PCI or conservative management, it didn't make any difference whether you went on to have death or non-fatal MI, the things that I care about, right? That's what I really care about. What they did find, though, is that early on in that 24 months, you were more likely to die if you were in the PCI group. Now, why would that be? There are 2 reasons I can think of why that might be, but these were randomized. So one of the reasons that it might be is they're sicker. Well, actually, they weren't sicker because these were randomized people. They took the medical, oh, this one looks a little sicker to me, let's take this. They took that out. So why might the early invasive group die more often? Yeah, occluded stent. They had a procedure done. It was related to the procedure. And actually, the abstracts that follow this out, that take it all the way to the end, abstract number, whatever it is here, the last one, 13, follows them out 3 and 4 years. And that's exactly what they found. They found that any difference in death was related to the procedure itself up front. That otherwise, the benefit you got was nothing. And by 4 years, everybody was the same. So you were honestly better off getting conservative management. And this is, and the way where this is trickling down is now the CMS and the people that pay us are looking at cardiologists with a very, very fine, sort of microscope. And if cardiologists are putting in a lot of stents in people that aren't having STEMIs, if they're doing a lot of stents in this NSTEMI unstable angina group, they're getting basically reamed. Because there is no indication for this. It does not help. You would think it works. It doesn't. The literature is rife with papers that say it doesn't. So NSTEMI patients, but definitely unstable angina patients, it doesn't really work. There's one tiny subset that there's a question, but overall it doesn't. And it's not our decision. But we don't basically, it's not something that's being charged ahead for. So not helpful at all in this. So to summarize the first part of this NSTEMI thing, David's going to cover the second part later this afternoon, is be a little bit critical of guidelines. Just because it's a guideline doesn't mean you have to do it. Heparin, really don't go down the slippery slope with heparin, okay? If they have a stent, sure. If they're really, truly NSTEMI, you're really worried, okay. But I'm just a little worried, don't expand it to that sort of softer, squishier group. Statins, you do not need to start them, okay? You don't let the cardiologist do that. You don't need to do that. Early invasive therapy, not a way to go. Okay, not a way to go for these particular people. And I love David, his little acerbic comment at the end here is, the ACC AHA guidelines lead something to be desired. It's sort of an understatement and then some. So any questions? Yeah? With CABG, actually CABG has almost fallen off the map. CABG is really, the indications for true bypass are very, very small now because PCI has become so good and targeted. So CABG is really, what CABG is unamenable lesions to stenting. I can't get there, basically, and they can get to almost all of them now, and not too much ratty disease where CABG is just going to feed a vessel into another bad part of the vessel. It's this little tiny category now where CABG actually applies, or failure of stenting where somebody's actually infarcting, and then they go to CABG. But CABG is gone. Cardiothoracic surgeons are twiddling their thumbs these days. All the valve stuff's being done by IR. All this stuff's being done by cardiologists. They're twiddling their thumbs these days.